So without further ado, I'm going to hand it over to Stacey Stuhrenberg. She's an auditor in our coding and compliance department, and she is well-versed in E&M codes and all the changes that are coming up. So Stacey, if you want to go ahead and get started.
Good morning, guys. I appreciate you taking time out of your day to join us. I know everybody's really busy and it's a really weird time. So again, I appreciate your attendance. As Jessica said, my name is Stacey Stuhrenberg. I'm a senior coding and compliance auditor with Kraft Healthcare Consulting. I've been in healthcare, 20 plus years. So hopefully you'll learn something today and be glad that you attended. So there is a lot of information contained on these slides. You'll be able to download the slides, as well as I attached the AMA medical decision-making grid that you can download as well. I will try to cover as much of this information as possible, but in the event we don't get to everything, you'll at least have the slides that you can go back to and refer to and look at. I'm going to talk about as much of it as I can, but we will move fairly quickly. And just a quick disclaimer, this is designed for basic coding and billing information. It was accurate when we did it. It's not, it's intended as an educational guide, not as a legal or consulting opinion. The goal of today's presentation is we're going to try to provide an understanding of the rationale behind the changes. We're going to discuss the new definitions, the guidelines and code revisions of CPT codes 99202 and 99215, changes to and addition of prolonged service CPT codes, and the criteria for code selection based on the table for risk medical decision making and time. It's my understanding, based on all the information that's presented, just FYI, everything we're going to talk about today is for these office visit and other outpatient services code 99202 to 215. But the AMA is going to continue to go by sections, and there's not a timetable, but they're going to keep updating the section by section of all the evaluation and management codes. Time for a change. Why now? Why did CMS, AMA all of a sudden decide to change? In 2019, CMS made the following changes and to start the process of reducing the provider burden. They eliminated the requirement to document medical necessity of furnishing visits in the home rather than office. Used to you had to say why a doctor went to, the person could not come to the office because of X, Y, and Z. Well, now that you no longer have to document that. Elimination of requirements for clinicians to re-record elements of history and physical exam when there's evidence that the information has been reviewed and updated. Physicians must only document that they reviewed and verified information regarding the chief complaint and the history that's already recorded by ancillary staff or the patient. According to AMA, for decades, the physician community has struggled with, burdensome, heavy reporting guidelines for reporting office visits and E&M codes. And with the rapid increase of EHRs into physician practices, documentation requirements for office visits has moved forward to increase. And what's happened is, because of the way these EHRs were built, you had a lot of template-driven. You had stuff that would carry from one visit to the next, and it created what in the industry we call note bloat. And that's basically because of the checkbox nature to try to meet some of those documentation requirements. In 2019, CMS was going to release an additional HCPCS code for Medicare patients only, which would have meant you would have had two sets of code, one for Medicare and one for everybody else. And the AMA stepped up and said, hey, wait, we don't want to really do that. Rather than utilizing two code sets, can we just have one? The rationale of the changes were a part of CMS's patients over paperwork initiative. The changes were intended to allow physicians and other qualified healthcare professionals to take care of their patients. Again, to reduce note bloat, which was the mandatory reporting of history and physical exams. Providers were having to wade through a lot of information, in some cases that were outdated and irrelevant, and now the focus is to make sure providers are creating clinically relevant notes. And CMS also believes that this is a way of addressing physician burnout. If you look at this came straight from AMA, the principle and the action. This is, they said, why are we going to do this? Well, we're going to do it to decrease administrative burden. We're going to decrease the need for audits, or they hope. They're hoping by providing, as far as audits are concerned, they're hoping by providing more detail in CPT codes that they'll have payer consistency. And if the audits are performed, and to promote coding consistency, because even out there between the MACs and the regions, we always know there's a little bit of difference in our commercial payers, Blue Cross versus UHC, Aetna, whatever. But with Medicare, even the regional MACs, there was some differences in how those were done. So they're hoping that they can get it more uniform. To decrease unnecessary documentation that's not needed for patient care in the medical record. On a minor or a self-limiting problem, we don't always need a physical exam, but with it being required in a CPT code, it was like, okay, well, I got to do a physical exam. That's not the case now. We're going to talk more about that in a minute. To ensure that payment for E&M is a resource-based and has no direct goal for payment redistribution between specialties. Use current MDM criteria, CMS, and educational/audit tools to reduce likelihood of change in patterns. Again, this goes back to the physicians being able to care for the patients, having to be able to focus on what is clinically relevant, why they're there, what they're doing, when they're there, and how they made the decision to care for them. And the next slide, this just shows you from July 1st, 2017 to July 30th, 2018, the upcoding errors. And this came directly from Medicare's website. It's their type of services with upcoding errors. You see that, on new office patient visits, there was a 10.6% improper payment rate. And with established patients, it was only 2.6%, but there's not a whole lot of difference in the improper payments that were projected. So, okay, we know why they did it. So what now? In 2020, currently, we have a history, an exam, a presenting problem, and medical decision-making or time. That's how we decide how we're going to select a CPT code for an office visit. But effective January 1st, 2021, we get to say, okay, we're going to choose a CPT code by a medically necessary history and exam, plus the medical decision making. And where we've got medically necessary, we're going to talk about that in a minute, but it's medically appropriate. Or total time, and you notice down there the day of. That's really important for you to remember. Evaluation management, guidelines, and code revisions. So now let's talk about a little bit about the revisions and the guidelines. What's changed? Medically appropriate history and or exam replaces the history, exam, and medical decision making for office visit code ranges 99202 through 99215. And you see everything you see on these slides, you see that I start with 9902. Well, that's because 99201 is being deleted, and we'll talk about that effective January 1st, 2021, but we'll talk more about that in a minute. I want to remind people, this is really important that providers understand. They should not interpret this change to mean that the documentation of a history and exam is not necessary. A complete medical record of services rendered is important for a number of reasons, such as providing information for quality initiatives, continuity of care, and supporting medical decisions under scrutiny in legal cases. If all of a sudden they stop documenting a relevant, medically appropriate history or exam when it's needed, then they can be called into questions for legal reasons, audit reasons, a whole ton of things. So again, it's really important that they remember, just because it's not required, that doesn't mean you just get to say, I'm not going to do it anymore. If it comes into play where it was a part of the medical decision making, it was something to be considered, and that date of service, then it needs to be documented. Although the specific level of history and exam won't be a factor in the 2021 E&M code selections for office and outpatient services, accurate documentation of the visit, including a clear statement of any history, exam work, and exam work involved, is still an essential part of the medical record. All of that still plays a part. That medical record tells a story. It tells why that patient came in that day, and the physician, what went through, why they did what they did. If it was a part of their thought process as to making a decision for treatment for that patient, then that history and exam still needs to be documented. And again, we're going to talk about medical appropriate history. The nature and extent of the history and or physical examination is determined by, and that determined by is new. That's why it is sort of bold a little bit. It's by the treating physician or the qualified healthcare professional reporting that service. The care team can collect information, and the patient or caregiver can supply information directly via a portal or questionnaire that's reviewed by the reporting physician and other qualified healthcare professional. The extent of the history and physical examination, again, is not an element in selection anymore, but it is important if it is considered in the medical decision-making process. All right. I mentioned just a minute ago 99201. This code's been deleted. CPT codes 99201 and 202 require a straightforward level of MDM, and the suggested replacement code is 99202. And the thought process behind this was that providers won't see a new patient without some type of medical decision making. I mean, a new patient walks in the door, you don't know anything about them, so there's got to be some level of medical decision making there. So 99201 has been deleted. And if you notice, for those of you that aren't coders on the call, you see the star and the triangle. Anytime you see that star, that indicates that it's a telemedicine code. And you see that blue triangle, that means there was a revision made to the code. So that's what those symbols mean. But if you'll notice, I've got this underlined. Let me go through the description first. Office or other outpatient visit for the evaluation and management of a new patient, which requires a medically appropriate history and or examination and straightforward decision making. When using time for a code selection, 15 to 29 minutes of total time is spent on the date of the counter. Okay, those are really important. And I have a section on time that we're going to get to, but what they tried to do is take some of the ambiguity out of the code selection. As coders, there was a time where we would sit and we would go, it'd say, okay, 5 to 15 minutes or whatever the case may be, and you're like, okay, how much of that does it really need to be? And then again, they also put in here that we talk medically appropriate history. You know, if I come in for an ankle sprain and I'm heavy, you know, I'm a new patient and I'm just in there, you don't need to look at my throat for the ankle sprain unless I tell you that something else is going on or you deem it medically necessary or medically appropriate, I should say. Again, 99203, if you notice, same thing, but it's got 30 to 44 minutes of total time spent on the date of encounter. 204, 45 to 59 minutes total time, and 205 is 60 to 74 minutes of total time. And then for services 75 minutes or longer, see Prolonged Services Code 99XXX. They have not given us that code yet. That's why you see the XXX. And we're going to talk about that code in a few minutes, but that's going to be your new Prolonged Services Code for office visits. And then here's your established patients. Again, you'll see that blue triangle telling you that it's a revised code. And you see the star letting you know that that is approved telemedicine code. And you've got for 212, you see that it's 10 to 19 minutes of total time. And then for 211, this is an established patient, you know, minimal. This is, you know, same rules that we had before on that. 213 is 20 to 29 minutes of total time on the date of the counter, and 214 is 30 to 39 minutes of total time. And again, the keys to remember about these new descriptions are medically appropriate history and or examination, and 20 to 20 and the time spent on the date of the encounter. And we'll talk about that when we talk about leveling and selecting a code. And you're going to hear me repeat that over and over again because it's really important that you get in the habit of understanding. And when you talk to physicians or coders and things like that, they need to understand, you know, medically appropriate history and or examination does not mean you don't ever have to do it. It does not mean that doesn't have to be documented. All it means is those are no longer elements in choosing the appropriate CPT code. They're not used to score the code as coders would typically do when they choose or level a code for evaluation and management. And then 215 is 40 to 54 minutes. And again, you see that on there. It references that new Prolonged Services Code that we talked about. So now I'm going to talk to you about prolonged services guidelines and code revisions. The first set is CPT codes 99354 to 99357. And these are prolonged services with direct patient contact, except for office visits and other outpatient services. You no longer use these 99354 to 357 with code range 99202 or 215. These are used by facilities for patients in inpatient observation or outpatient settings, not office visits. 99354 and 355 are used to report the total duration of face-to-face time spent by a physician or qualified healthcare professional on a given date providing prolonged services in an outpatient setting, even if the time spent by the physician or other qualified health professional on that date is not continuous. 356 and 357, those are used to report the total duration of time spent by a physician or other qualified healthcare professional at the bedside or on the patient's floor or unit in the hospital or a nursing facility on a given date, providing prolonged services to a patient, even if the time spent by the physician or the other qualified healthcare professional is not continuous. Time spent performing separately reported services other than E&M or psychotherapy is not counted toward a prolonged services time. You can't double dip. You can't bill it and still call it a prolonged service. Code 99354 or 356, it's used to report the first hour of prolonged services on a given date, depending on the place of service. Either code should be used only once per date, even if the time spent by the physician is not continuous on that date. So again, you can only use it once per day. 355 or 357, if you notice that little plus sign, that's your add-on to let you know that this is an add-on code. So 355 or 357 is used to report each additional 30 minutes beyond the first hour, depending on the place of service. Either code may be used to report the final 15 or 30 minutes of a prolonged service on a given date. Prolonged services of less than 15 minutes and beyond the first hour, or less than 30 minutes beyond the final 30 minutes, is not reported separately. And I'm sort of going through these quickly because that's not what today's webinar is about. But since these codes used to be used with these, I thought it was important that you guys realize that they were revised and they were changed. So again, you'll have these slides and you can refer back to them, and it has this information on it. Prolonged services of less than 30 minutes total duration on a given date is not separately reported. And again, anything with a plus sign is an add-on code and reported in addition to the primary procedure or service. And we talked about these 356 and 357 already a little bit, but you'll see inpatient or observation setting requiring unit or floor time beyond the usual service. That's the key. And again, anytime you use, it's really important to remember also, anytime you are billing for additional time, that has to be documented. We have to be able to see or for that medical record to be complete, we need to know how much additional time was spent and what that time was spent on. Um, 99358 and 359, these are prolonged services without direct patient contact. Use 99359 in conjunction with 358, and you do not ever report this on the same date as you report the new CPT code that we're going to talk about, 99XXX. You don't use these with office visits. CPT code ranges 99202 through 215. You don't report in the same month with 99484, 99487, and 489, or with 99490 through 99494. Don't report when during the same times of codes 99495 or 99496. If you are reporting 495 or 496, so be really careful about that. 99358 and 359 are used when prolonged service is provided that is neither face-to-face time in the outpatient, inpatient, or observation setting, nor additional unit floor time in the hospital or nursing home setting. This may also be used for prolonged services on a date other than the date that is related to a face-to-face encounter. An example of this would be an extensive record review that may relate to a previous evaluation and management service performed at an earlier date. However, it must relate to a service or a patient where face-to-face time care has occurred or will occur and relate to ongoing patient management. So, if the physician did really, again, extensive medical record review prior to seeing that patient. Don't report 358 and 359 for time without direct patient contact reported in other services such as care plan oversight, chronic care management by a physician or qualified healthcare professional, home or outpatient INR monitoring, medical team conferences, interprofessional, telephone, internet, health record consultations, or online digital evaluation management services. Because again, those all have CPT codes. They can be separately reported. You don't want to double dip. You don't want to report. You can't count time here and then report it with another CPT code. 99358, if you notice, it can stand alone. 99359 can't, because if you notice, it's got that plus sign, so that means it's an add-on code. But 99358 can stand alone. Codes 99415 and 99416. If you notice that number sign, we didn't talk about that. And again, I'm going through this for all the non-coders on the phone, but that just means it's out of sequence in the code book. But these codes are for prolonged clinical staff services with physician or qualified healthcare supervision. For prolonged services by a physician or other qualified healthcare professional, you don't report these with 99415, 416, and you can't report 99416 with 99354, 355, or the 99XXX. Facilities cannot use these two codes, the 99415 and 416. Because if you notice, prolonged clinical staff services, the services beyond the typical service time during an evaluation and management service in the office set or outpatient setting, direct patient contact with physician supervision, first hour. Codes 99415 and 416 are used when prolonged E&M services are provided in an office or outpatient service, even if the time spent by the clinical staff on that date is not continuous. Prolonged services of less than 45 minutes total duration on a given date is not separately reportable. Clinical staff is providing the service, and the physician or the qualified healthcare professional is present to provide direct supervision. These codes may not be reported for two simultaneous patients. Codes 99415 and 99416 may be reported for no more than two simultaneous patients, which we just said. The use of time-based add-on codes requires that the primary E&M service has a typical or specified published, which ours do now. It gave you that. We talked about that a minute ago. These codes cannot be used in conjunctions with 99202 through 99205 or 99211 through 99215. So you can use these codes with any of the office visits. Here's our new code, CPT code 99XXX. The description that, and again, for the non-coders, that's what that red circle means. It means it's a new code. It means it's an add-on code, and this is approved for telehealth. The description, the new description, prolonged office or other outpatient evaluation and management services beyond the total time of the primary procedure, which has been selected using total time, requiring the total time with or without direct patient contact beyond the usual service on the date of the primary service, each additional 15 minutes. This is listed separately in additions to codes 99205 and 99215 for office or other outpatient evaluation and management services. So this code can only be used with 99205 and 215. You can't use it in conjunction with 354, 355, 358, 359, 415, or 416. And you can't do it for less than 15 minutes. This, the new CPT code coming, 99XXX, is for prolonged it's a prolonged service code with or without direct patient contact on the date of an office or other outpatient service. Again, it's going to be with 205 or 215. You can't report it with 354, 355, 358, 359, 415, or 416. It's only used when the office or other outpatient service that's been selected using time alone as the basis, and only after the total time of the highest level of service. I have a table on one of the next slides. We'll show you how to use it. But this is used when you are doing that time-based coding. Again, you can't report it for less than 15 minutes. It's prolonged services on a date other than the date of a face-to-face encounter, including offices. You look at the 358 and 359. Time spent performing separately reportable services other than E&M is not counted toward the time for 99205 and 215 and the prolonged services time. Again, those are separately reportable. You can't bill twice for the same time. And here's the table that we talked about. This is for a new patient. So if you spend less than 75 minutes and you've already decided your code is a 205 based on time, then you cannot report it separately. But if you spend 75 to 89 minutes, it's going to be 99205 with 1 unit, and then this 99XXX times 1 unit. 90 to 104 minutes, same thing, your 205, 1 unit, but your 99XXX goes to 2 units, and then 105 or more minutes, you've got 3 units or more for each additional 15 minutes. So basically it's showing you use your code and then you use your add-on code, and the number of units for that 99XXX is based on 15-minute intervals. Tongue-tied this morning. And then here's the same table that we talked about, but this one is for an established patient. And you'll notice where the new patient was 75 minutes, the established patient, it's less than 55 minutes. And then you go from 55 to 69 minutes, 70 to 84 minutes, or 85 or more minutes. Again, you notice that your units are by 15-minute intervals. So enough about prolonged services. Let's talk about our new MDM, our medical decision-making definitions. The panel used the current CMS table of risk as a foundation for designing the revised requirements for MDM. And from what I understand and all the things I've read and watched, they took our table that we currently used column by column and said, okay, we're going to try to, again, remove ambiguous terms like mild and define and ambiguous concepts, acute or chronic, with systemic symptoms. They also defined important terms like what is an independent historian. They redefined the data element to move away from simply adding up tasks to focusing on tasks that affect the management of a patient. For example, independent interpretation of a test performed by another provider and or discussion of a test interpretation with an external physician or specialist. The problem addressed. The new MDM table includes a column titled Number and Complexity of Problems Addressed. According to 2021 CPT definition, a problem addressed or managed is one that the provider evaluates and treats. So consideration of further testing that is decided against becomes risk involved or patient choice. It can be counted and will be addressed. This is an important point that recognizes that provider work involved in evaluating options for patient care and making recommendations, even if the patient decides to follow a different course. And one of the things I really like in a lot of the definitions now, they gave examples, but you'll see that in some of the other definitions where they provided an example in the actual definition that says, here's what this would or would not be. We, prior to 2021, a lot of this stuff was a little bit gray, what I might consider, a moderate or chronic, or a condition. You may not, depending on what they were being seen for. So they tried to take some of that out. A problem is a disease or condition, illness, injury, symptom, sign, finding, complaint, matter addressed at the encounter, with or without a diagnosis being established at the time of the encounter. So again, I say all this because you'll notice the consistency of at the encounter, so that things that, if I came in and I have, I'm recovering from pneumonia, but it's not addressed at the encounter, then it didn't come into play. It's not considered part of the problem. And then minimal problem, self-limited or minor problem. A problem that may not require the presence of a physician. That's our nurses' visits, that 99211. Self-limited or minor problem. A problem that runs a definite and prescribed course. It's transient in nature and is not likely to alter permanent health status. Stable or chronic illness. Again, this is where those examples start to come in, because if you look right here, you'll see, for example, a patient with persistent, poorly controlled blood pressure for whom better control is the goal is not stable, even if the pressures are not changing and the patient is asymptomatic. The risk of morbidity without treatment is significant. Examples may include well-controlled hypertension, non-insulin dependent diabetes, cataract, or benign prostatic hyperplasia. So again, they did add those examples in there. We've got, they've defined acute uncomplicated illness or injury. They've also defined chronic illness with exacerbation, progression, or side effects with the treatment. And again, if you look at that acute, they gave you examples: cystitis, allergic rhinitis, or simple sprain. Undiagnosed new problem with uncertain prognosis, acute illness with the systemic symptoms. COVID, our current pandemic, is a great example of acute illness with systemic symptoms. Acute uncomplicated injury. And I'm not going to read all these definitions again. You'll have the slides. You can go back to those. And then chronic illness with severe exacerbation, progression, or side effects of treatment. Acute or chronic illness that poses a threat to life or bodily function. And then we get into definitions where the amounts of complexity of data. And when we go to the table of risk towards the end of this presentation, all of this stuff is in those columns and will come into play, but they have defined it as to what they are. Test, imaging, lab, psychometric, psychological data. A clinical lab panel is a single test. The differentiation between single or multiple tests is defined in accordance to the CPT code sets. And then you've got external physician or other qualified. They've gone to great lengths to give you these definitions and take some of the guesswork out. And here we talk about independent historian. Really quickly, I won't get bogged down, but I'm married. And so when I go to the doctor with my husband, I wouldn't be considered an independent historian because my husband can speak. He just chooses not to, and I'm usually right, so I give all the facts. But the doctor can't count me as an independent historian. However, if I am a mom at a pediatrician's office and I take, my baby in, my baby can't speak for themselves. So, same thing with a aging person with maybe dementia, and so whoever's taking them. Those are examples of independent historians. They provide a history in addition to a history provided by the patient who is unable to provide a complete or reliable history. So I go back to the example of my husband and I. I'm not his independent historian. He just chooses to not provide the history. Independent interpretation, appropriate source. Again, they've gone to great lengths to try to give definitions and meanings to remove, I should say, some of the stuff that wasn't the ambiguity, I guess is the best word for it. Medical decision making, risk, and morbidity. Risk. For the purposes of medical decision making, level of risk is based upon consequences of the problems addressed at the encounter when appropriately treated. Risk also includes medical decision making related to the need to initiate or forego further testing, treatment, and or hospitalization. Again, I just can't say enough good things about the definitions. I think they're great. Social determinants of health. Again, if somebody's homeless or if they're older and they live alone, these are really important because they can influence that person's proper care. Do they have a support system in place where they can get appropriate care? Do they have access? So it's really important because these go to medical decision making. If it's an older person and they have no support system in place, the physician's going to think, well, how do I handle this? So that does come into their thought process. That is a part of that medical decision making. Drug therapy requiring intensive monitoring for toxicity. Again, it gives you examples. It tells you that monitoring does not qualify, that, like monitoring glucose levels during insulin therapy as the primary reason is the therapeutic effect, or an annual electrolytes and renal function for a patient on a diuretic as the frequency does not meet this threshold. Now, I do know that Palmetto, GBA, and I have the link in there. They have examples. They have a list that says what meets this requirements. I have not looked at some of the other MACs, but again, I know AMA and CMS were trying to make this as uniform as possible, but I did put the link for Palmetto in the resources at the end of this presentation. And here's a little bit more about the drug therapy for intensive monitoring. The drug can cause serious morbidity or death. Monitoring accesses adverse effect versus not the therapeutic efficacy. So your monitoring makes sure that their blood levels are one way or the other, because basically it can kill them if you don't. The type of monitoring used should be generally accepted kind for that agent, although patient-specific monitoring may be appropriate too. Monitoring may be long-term or short-term. Long-term monitoring occurs at least quarterly. Lab, imaging, physiological tests are possible monitoring methods. History and exam is not. It has to be a tangible thing that you're doing. Monitoring affects MDM level when the provider considers monitoring a part of the patient management. So those are really important, and I would encourage everybody that is in this region to go look at Palmetto's. If not in this region and you want to see something, see if your MAC has something out there, just shoot me an email and I'll see what I can find for you. But I do, like I said, I do know Palmetto has one. and I have included the link at the end of the presentation. Now we're going to talk about selecting the code, the fun stuff. Code selection, evaluation and management code selections effective January 1st, 2021 is going to be based on the level of MDM defined for each service or the total time for the E&M services provided on the date of encounter. Both 20 and 21 guidelines have 3 components to the MDM with basically the same names. Now you'll see the red on the slide, that is the revised portion. The current MDM was like what we have now was number of diagnosis or management options and amount and or complexity of data to be reviewed, risk of complications and or morbidity or mortality. Now we have, again, we talk about that addressed at the encounter, number and complexity of problems addressed at the encounter. That is so very important. And then they added to amount and or complexity of data to be reviewed and analyzed. And then the last one changed a little bit, risk of complications and or morbidity of patient management. The MDM levels are still straightforward, low, moderate, or high. There is no MDM for 99212. MDM may be influenced by role and management responsibility. Again, you know, a lot plays into that, but, you know, is the patient living alone without a support system, an elderly couple who may need additional supports, a special needs person who may need additional support. So all of that comes into play. If the physician thinks about it when he's going through the thought process of medical decision making, then it takes a part. It is a part of selecting that code. History and physical exam. Again, we talked a little bit about this. While it is not necessarily required for all the codes, it does include a medically appropriate history and or physical exam when performed. Extent of history and exam is not an element, but while it's not an element, it still needs to be documented if it was a part of the medical decision making for that encounter. The nature and extent determined by the treating physician or NPP reporting the service. The care team can collect the information. Again, that goes back to what we talked about. You just have to make sure that the documentation includes that it was reviewed and it was considered. Patient or caregiver may supply information directly via a portal or questionnaire. Information provided must be reviewed by the physician or NPP. You know, while the physician's work in capturing a patient's pertinent history and performing a relevant physical exam contributes to both the time and medical decision making, these elements alone are not going to determine that appropriate code level. But if it was considered, it needs to be documented. It'll support the complexity of the patient. No documentation, you know, there's no change in that. And the only problem I have is right now, when they did all these definitions, they didn't do a definition for medically appropriate. They just said that the physician or the qualified healthcare professional should ask themselves, if there is no HPI, will they be able to support the medical complexity associated with the encounter? So if I came in with a problem with my knee and the physician decides that, gosh, I might need steroid injections, but then he says, okay, I'm diabetic. Well, if he didn't have that history and know I was diabetic, he had to include that with those steroid injections. So that was a part, and it was addressed. He's going to ask me questions about that before he gives me a steroid, because I'm diabetic and, medications interact, so on and so forth. Number and complexity of problems addressed. Multiple new or established conditions may be addressed at the same time. They may or may not affect the MDM. Symptoms may be for a specific diagnosis. Each symptom may not necessarily be a unique condition. Comorbidities or underlying diseases not considered in selecting an E&M level. Again, this is what we talked about. Comorbidities in any disease I have, unless they are addressed and unless comorbidities, underlying diseases increase the amount and or complexity of data to be reviewed or analyzed, or it increases the risk of complications and or morbidity or mortality of the patient management. It has to affect me on that date of service. The physician has to know I have it. He had to think about it, and it had to come into play as to what he was going to do and why he was going to do it. Multiple problems of lower severity may create a higher risk due to interaction. The final diagnosis for a condition does not in itself determine complexity of risk, as extensive evaluation may be required to reach the conclusion that the sign or symptoms do not represent a highly morbid condition. Multiple problems of a lower severity in an aggregate create a higher risk due to interaction. So again, if I've got a lot of conditions that are coming into play, but we won't call them severe, they may be lower in severity, but it's all about how severe the provider documents the patient problem is. If I've got all these problems and one, in and of themselves, each individual condition is not severe, but you put them all together and the physician says, holy moly, these are, not good together. They can cause huge, huge problems. If you only had one, it may not be as big of an issue, but when you take the whole picture together, it becomes a real issue. So again, it's all about how that physician documents, and he says, as to how it plays into the number and complexity of problems addressed. Amount and or complexity of the data to be reviewed and analyzed. That includes medical records and tests. Other information must be maintained, ordered, reviewed, and analyzed for the encounter. May be obtained from multiple sources. May be obtained from interpersonal communications that are not separately reportable. Ordering a test is included in the category of the test and review of the result in that part of the encounter. And you can see all of this about the test and things like that on the MDM table itself. Again, I think I mentioned this earlier, when they created this new table, they did it column by column. And in this portion where the amount and the complexity of the data to be reviewed and analyzed, they divided it into three categories. Their thought, AMA and CMS's thought process was they tried to simplify and standardize contracting scoring. Again, we talked about how some of the MACs were different. They wanted to emphasize clinically important activities over the number of documents. They wanted to account for the quantity of documents because it is MDM work and it does create, so you still have to sort of count, but they tried to make it where, clinically important activities were more important than just 10 pages. But with that said, if there is a lot of documents that you had to go through that were clinically pertinent and medically appropriate, they wanted to make sure that was in the medical, that you got credit for that in the medical decision making. It was divided into three categories, which are tests, documents, orders, or or independent historian. Each unique item counted until threshold is reached. Again, the thresholds are listed on the table. Independent interpretation of test, discussion of management or test interpretation with external physician or QHP or appropriate source. These are your specialists outside of your office. Did you talk to a cardiologist? It's not in the office. It's not your nurse practitioner. It is external. That's really important to remember on that. And here is the level of decision-making table. I also attached the, just for you to be able to see it, because on the slides it's pretty small, so I attached AMA, the official AMA one, to the materials, and it's available for download. But straightforward typically means a self-limiting problem. Low, it's stable, it's uncomplicated, it's typically a single problem. Moderate, multiple problems, or they're significantly ill. High, they're very ill. And what I like about this is on the table they've grouped the new and established together. You've got 202, 212, and then you've got 203 and 213. And then it's basically set up in the same format as the table we have now, but they've just, again, they have simplified it and provided us some definitions so that we know how to use this. 202, 212 is straightforward, minimal, and minimal or none, minimal risk of morbidity from additional diagnostic testing or treatment. 203, 213 is your low. And if you look, you've still got your, where you would choose, but they have now, you've got these options, and it's just a lot clearer. 2 or more self-limited or minor problems, or 1 stable chronic illness, or 1 acute uncomplicated. And then you go to your amount and or complexity of data to be reviewed and analyzed, and it tells you right here, you must meet the requirements of at least one of the 2 categories, and then it's got it separated by categories. So any combination of the 2 of the following, there's your 1. You've got review of prior external notes from each unique source. So let's say you got one from you got records from my pulmonologist, and you got one from my cardiologist. Well, that's 2 right there. That's a combination of 2 just in that top bullet. Review of the results of each unique test, and we have our definition for test. Ordering of each unique test. Again, a panel counts as 1. It doesn't count for all the CPT codes included in that panel. Or category 2, assessment requiring an independent historian for the categories of independent interpretation of tests and discussion of management or test interpretation, see moderate or high. So I think they've done a really good job of taking some of the, I keep using the same word, but really it's true, the ambiguity out of choosing these codes. And on the next slide, you see you've got your 204 and your 215, and you've got moderate. It tells you exactly what, for the number and complexity of problems addressed, it tells you exactly what's considered moderate. 1 or more chronic illnesses with exacerbation or progression or side effects of treatment, or 2 or more stable or chronic illnesses, or one undiagnosed new problems with uncertain prognosis, or, you go on. And then again, you've got it broken down into your categories over here. It says, you must meet at least 1 out of the 3 categories. You've got your category 1, category 2, and category 3, and it tells you what each one is under there. The first one, any combination of 3 or more of the following. So you meet that, and then you're at moderate. And then you've got your moderate risk. Examples are prescription drug management, decision regarding minor surgery, decision regarding elective major surgery, diagnosis or treatment of significantly limited by social determinant of health. That's what we talked about a few minutes ago when I was telling you that social determinant of health comes into play. If you've got an elderly couple with no support system or elderly person with no support system, that comes into play in how you can treat certain conditions and what you treat them with. Prescription drug management, I want to talk about that just for a second. Some of the MACs have definitions out there as to what meets that. So again, if you have questions about what that is, let me know. Your MAC, some, not all, but some have definitions out there for that already. And then we've got your 205 and 215. And, you know, it goes through here. Here's our drug therapy requiring intensive monitoring for toxicity. Elective major surgery, you know, with identified patient or procedure risk, blah, blah, blah. But the key to all this is it's pretty clear on this table when they came out. There's still some questions and there's still a few things out there lingering about it. But for the most part, they did a great job on that. And the thing to remember is when you're using this table to qualify for a particular level of MDM, 2 of the 3 elements for that level of decision making must be met or exceeded. So, and it's on the table itself. It says that on it. So let's say if we go back, let's say we've got straightforward or minimal. We'll say we've got minimal number of problems addressed, but maybe we've got a limited number of amounts and data of complexity that are reviewed and analyzed, but then we've got moderate risk of complications. So in that instance, you've got to meet or exceed. So your code would be in this 203 or 201 because you didn't exceed to get to that higher level. You had 1 below, 1 above, and 1 in the middle. So it is going to be, you have to do 2 out of the 3 elements and you have to meet or exceed. So it's really important. That's the same as we're doing now. The concept's unchanged from our current guidelines. Let's talk for a minute about selecting CPT codes based on time. Under the 2021 E&M guidelines for 202 through 205 and 212 through 215, when selecting a CPT code based on time, it is based on the total time spent on the date of encounter, and it includes both face-to-face and non-face-to-face time. All right. It does not include time in activities normally performed by clinical staff. So currently, right now our guidelines tell us when we're selecting an evaluation and management code based on time, counseling and or coordination of care dominates the encounter. Over 50% of the time spent in that encounter was due to counseling and coordination of care, and it was only face-to-face time counted. Effective January 1st, 2021, time can be used to select an E&M code whether or not counseling and or coordination of care dominates the services or not. But this is only applicable to these CPT codes that we've been talking about, the 202 through 215. All other E&M codes, this doesn't apply to. And total time, and it's also total time on the date of encounter. According to AMA, the key elements addressed regarding when thinking about the time, we go back to that word I've used throughout the presentation, was ambiguity. You know, what is the exact increment of time I can move to the next level of code? Which elements of my visit can be included as a part of my E&M, and which should be reported separately or not at all? And then they felt like it was too restrictive. Why can't E&M codes be more flexible to allow the most accurate elements to be considered in code selection rather than just saying, okay, counseling and coordination of care dominate more than 50% of the visit? So they really tried to look at this. Let's talk about what time includes. Physician or qualified healthcare professional time includes preparing to see the patient. You're reviewing tests. You're reviewing other physician or specialist records, test evaluations, obtaining and or reviewing separately obtained history, performing a medically appropriate examination or evaluation. Again, it's that medically appropriate. Counseling and or educating the patient or family or caregiver, ordering medications, tests, or procedures, care coordination that's not separately reportable. Always, 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 when you're thinking about time, is it reportable? Is it not separately reportable? Because you can't double dip on the time. And again, if you're billing by time, the documentation has to say how much time was spent and what it was spent on. Documenting clinical information in the electronic or other health record, referring and communicating with other health professionals when not separately reported. Examples of like reviewing other patient tests and history and that kind of stuff. Maybe you talk to a teacher or guidance counselor at school due to ADD. Referring and communicating with other care professionals when that is not separately billable. Again, don't count any minute twice. Chronic care coordination or transitional care management. Those are separately reportable. Now that we've gone through all of that, we're going to talk just a second on the electronic health record vendor. It's extremely important that practices communicate with their EHR and billing system vendors to educate themselves on updates being done on the 2021 changes. Are they ready for it? What are they doing about it? How are they going to know, because a lot of the systems have rules engines, they have templates that can be built, they have check boxes. You have to know as a practice or a provider how those codes, what's driving those codes, how are they being selected, what is the system set up to do, and you need to make sure both the staff and the providers are educated on how the system is set up to handle the new guidelines. So, questions that you want to ask your vendor: has the vendor incorporated any of the new guidelines into their software system? If so, when are they affected? How will the system determine if the visit is based on time or MDM? How is time calculated? Has the system been updated to reflect that history and exam are no longer required? While you may do a medically appropriate one, it's not counted. It needs to be in the documentation, but it is not used to, it is no longer a requirement anymore. Those are just a few of the questions. And for those of you that have your EHR vendors, it's really, really important that you understand how they are set up so that the staff and the providers understand if they check a box or they put something in a field, how that affects and if it's going to affect the code that is selected. I did not run over, which I'm really happy about. I'll bring this back in just a second, but I want to talk a little bit about the resources really quickly. I have put on here links to AMA, the prolonged services. There is a link to the evaluation and management revisions. There is a link to the CPT revised MDM grid, which I've attached. You also have a link to CMS's MLN network for outreach and education that is on the evaluation and management codes. And then this is that link for Palmetto that we talked about drug therapy requiring intensive monitoring. This link is awesome, and it gives you that information for Palmetto. And again, if you need to email me and ask me questions about other MACs, I can look and see, but I do know those are the ones for Palmetto. Here is my email address. Stacey with an E at crafthealthcare.com. There's my phone number. I will be happy to answer any questions that you have. Just send me an email and I will respond in a timely manner and get you the information you need. Hopefully this was helpful. For those of you that have practices, we do offer provider education where we can set up webinars. We can do Zoom, and if you're local, we can talk about coming on site and helping you with any of the provider training. But it is so vitally important that your staff, your providers, everybody in the office is educated, and they're going to have to realize that you can't just throw your 2020 stuff away because you got 2020 guidelines, and then that's another question for your EHR vendor. You got to make sure that, December 31st, that's still a 2020. January 21st is 2021. So make sure they know the difference and what's driving it, and, have a checklist. If you need support systems, again, we're certainly willing and ready to help you guys with that. So with that, I am going to end today's webinar, let you out 15 minutes early because I know you're all really busy. But again, I hope it helped, and thank you for your attendance.